So hi, my name is Norma. I'm with Clinical Information Systems. I think I pretty much recognize almost everybody here. I get to talk about everyone's favorite topic, documentation. And everyone loves this. Okay, so they gave you a beautiful handout up there that told you exactly what you need, what's a basic or complete neurological assessment. My biggest thing is make sure it is thorough and timely. A lot of these are, it's the smallest things sometimes. Oh, they do have it, right? Oh, okay, well, sorry, there's some in back that tells you. Yeah, sorry, there is some there. I saw the paper in back, but hopefully you can grab one. But anyway, timely and thorough. And make sure you do a complete one because, again, it's the smallest little things that can notice a difference. Smallest change might be level of conscious change, right? Alertness status. By the time they get to the blown pupils, we're already kind of at the later stages. So again, nice and timely is great. Now this one came up in another survey, and that's that button that we have that says no change from previous assessment. One, definitely we cannot use it if we did not use the first assessment. But the question always comes up with this because they said, did you really do all the assessment you did previously? Or are you just clicking, no change from previous? So for these guys, especially for your stroke patients or your neuro patients, honestly, I would avoid using these and just fill out the assessment again. Because that's a question that always comes up with Joint Commission is, did you really do all of it or did you just click it? Okay, and so this is the baseline assessment, and I saw you had a beautiful paper in the back. A lot of the charting did change in Power Chart. What they did was they shortened things up so everything's not wide and open, which I actually like because it's easier. Let me flip over to this one. So this is what it looks like when it's wide open. Now, if you are on the medical floors or on the unit, it is under either Systems Assessment CC band or the Systems Assessment HW. It's the exact same thing. And essentially to find it, you're going to go into your neurological, your cranial, and your musculoskeletal to get these major ones. Essentially, you're doing all the LOC, orientation, speech, cranial nerves 2 to 7 and 10, which is your swallow, strength, sensation, and gait, which all lives under musculoskeletal. What a lot of these are now is their conditional field. So all these are closed until you open up the first one with the little diamond with the arrow. Once you open that, it'll open up all the documentation that you need. So they kind of made it a little smaller and cuter so it's not so huge. But in case you see this, that's how you open it. We still have to do our NIH scales as well as our swallow screens. Again, if you're not sure what to do with the outcomes, just click on these lovely little blue links. It'll actually tell you what you're supposed to do if they pass or fail. Now, I know you asked earlier what happens if they do fail, but we know we still have to call it speech. Because in the end, we put fail, because technically they failed, right? Because they failed this. They will still look at it, and they're still going to ask you, if you said fail, why are you giving a medication? So unless we have some kind of physician thing that says okay or something else, we can't just give it, even though we think, oh, the droop is from something else. So that's where we have a limitation for. Okay, for ED, you guys are actually a little easier. If you guys actually use the focus assessment, there's actually a neurological one. Everything is right there. All the way from your cranial nerves, your neurological, it actually has all the sensation and strength right there in one single row, including your NIH and swallow screen. So ED has it nice in the sense that you just go straight down. As long as you have that focus assessment ED band. If none of you guys do have that, please just let us know. We can show you how to pull it in. Okay, this guy we bring up because it's always an issue. Post-thrombolytic monitoring. Honestly, sometimes the tasks don't fire right. Someone doesn't put in the task. The order doesn't go right. So these tasks don't always drop appropriately. In general, just remember this. Every 15 minutes times 2, every 30 times 6, every hour times 16. And that's just standard. I don't care if you do it as more frequently, but don't do it less. Also, one of the things we found every time we work with Joint Commission is people start like the 30 minutes too early. So just remember, if you started at 2:15, the next 30 minutes does not start till 4:15. So we notice that's happening. They'll start the 30 minutes at 4 o'clock rather than 4:15. And they actually picked that up. And they're like, no, this is too early. You guys are actually missing a 15-minute check. So just remember what time you guys started, around like 2:15. Make sure you don't change to the 30 and the 1 hour until you hit that 15 minutes, the whatever 15. So that was just one thing we noticed with Joint Commission every time. This is another reminder. The other one is WDL. Be very careful with WDL, especially with Neuro, because that just means that you did every single one of those assessments. And honestly, you're not going to be doing the swallow eval over and over. I don't know how many of you guys do PERLAs all the time. Are you doing gait every single time? So you want to be careful about using WDL unless you really did all of these things. It's an all or nothing, and they all have to be normal. So I'm fine with WDL when this is not a neuro patient. They're in here for something else, fine. Another option that you guys do have, though, instead of WDL, is all the norms are right here under that same band. If you're like, everything's normal except one thing, you can just go right ahead and click all your normals out here and then go right ahead and put your abnormals. But we often saw this a lot where people put WDL, but we'll actually find like they can't move one extremity. We're like, wait, that's not WDL. So be very careful with this. These are things that kind of always get us into trouble. I'll be honest, it's a WDL and no change from previous. They're great in some instances, but if they are actually here for a neurological problem, I would avoid those two options. I would just go straight to the documentation.